Hello, I'm Dr. Tim Donnelly, and welcome to Uncomfortable Truths About Oral Hygiene. Here's how to finally get it right. As I sit here today, after almost 30 years of trying to manage chronic inflammatory periodontal disease in my patients, I'm ready to face some uncomfortable truths that I think have plagued periodontics seemingly since the beginning of time. Those uncomfortable truths are, number one, I think we're losing the war against plaque. We say we're all about prevention, and we haven't really prevented all that much. 57% increase in periodontal disease over the past 20 years. 60% of adults have some form of periodontal disease. What you, quote, deeply believe in because you've seen great results when patients use it, well, another uncomfortable truth is you're probably wrong about that. String floss, basically worthless, at least from most sites. Now, I know those are fighting words, especially with a predominantly hygiene audience, but at least give me a little leeway to make my case. Giving out free manual toothbrushes, which we've done over the last 100 years, makes absolutely no sense. And I'm going to ask you tonight to please stop doing that. Brushing and flossing, the bottom line, it doesn't work. Of these uncomfortable truths, we'll start here. We're losing the war against plaque. We have spent so long getting out the big plastic models, teaching people how to brush their teeth, and we feel great satisfaction when they master the technique. This is when I realized that we're really not winning the war. This was recently my Uber driver. And when my Uber driver found out that I was in dentistry, the next question was, hey, can you do anything about this? And of course, I took one look in the rearview mirror and I said, hey, I think you're going to need some professional help with that. And the patient waved me off and said, well, I think what I'm going to do is get a new toothbrush and really work at it for a while. Somewhere along the line, people have failed to get the message. This is the sixth leading cause of disease. People are walking around today with much worse periodontal disease than they had 20 years ago. We're not winning the war on periodontal disease. To do that, I think we have to refine dentistry. I think it's time to leave behind the limited image of the dentist as the senior member of the oral hygiene police, with the dental hygienist, the loyal foot soldiers in the war against plaque, and move forward and embrace the preferred concept of the dentist and hygienist as important members of the team necessary to help patients achieve better oral and overall health. The dentist and hygienist are playing increasingly important roles in helping patients achieve better oral and overall health. That's such a far cry from the message we've delivered in dentistry over the last 50 years, brush and floss or else. You know, the fact that brush and floss or you'll lose your teeth hasn't motivated the throngs of patients with unmet needs to come in and have those needs addressed. I don't think that's evidence that the message has failed to get through. You want proof? Tell anybody you're involved in dentistry. And typically, the first thing they'll do is start to confess their oral hygiene sins to you. Or worse yet, they'll hit us dental professionals with the tried and true question that apparently has plagued mankind since the beginning of time. Which is better, waxed or unwaxed? No, the fact that brush and floss or else hasn't motivated the throngs of patients with unmet needs to come in and have those needs addressed is not evidence that the message has failed to get through. I think it's confirmation that the message has to change. The message has to change. We have to refine dentistry based on what we know currently, especially about periodontal disease. Yes, it is bacteria that accumulates between the soft tissue and the tooth. And if that bacteria is left there long enough, if the patient isn't consistently adequate, or the patient isn't using what allows them to be consistently adequate in interrupting the bacteria, that bacteria starts to migrate underneath the gum. When that happens, the body recognizes it as foreign. The body mounts an inflammatory response. White blood cells, other inflammatory cells are recruited to the area and start to dump out a variety of mediators of inflammation. Among those mediators of inflammation are collagenases, which break down collagen. The reason periodontal destruction occurs is because the bone is mostly collagen. When bacteria accumulates, that local host response results in reduction of collagen and ends up leading to our beloved pocket formation and bone loss. But when that collagen is destroyed, we also lose integrity of the lining epithelium. The lining epithelium ulcerates. Bacteria, bacterial byproducts, and the mediators of inflammation released in response to that bacteria can find their way through that ulcerated epithelium daily in patients that have ongoing periodontal disease and travel wherever the blood goes. We now know without question that if chronic inflammatory periodontal disease persists, inflammatory mediators from the host response and the oral pathogens that initiate that host response absolutely contribute to the systemic burden of inflammation. That evidence is overwhelming. Even more importantly, medicine's long realized that systemic inflammation doesn't necessarily cause the chronic diseases of aging, the things that rob people of the quality and quantity of life. But clearly, systemic inflammation is what drives the progression of the chronic diseases. There's no surprise then that evidence continues to emerge and only strengthen that the keystone pathogens that are allowed to persist, that ultimately lead to that host response, absolutely have the potential to contribute to these chronic diseases. And once again, the evidence is overwhelming. Without question, patients that have ongoing oral disease are more likely to have a significant amount of systemic issues. And probably what gives us the most potential to redefine what dentistry is about, to completely change the narrative, is the also overwhelming evidence that helping patients achieve and then maintain a dentition that's relatively disease-free over time absolutely has been demonstrated to reduce the systemic risk. And this is one of the big changes that we have to come to terms with. What we're talking about is relatively disease-free over time. If we can help patients achieve a dentition that's relatively disease-free over time, there's no question that we're contributing to their overall wellness. And I think the light bulb has to go off. We're no longer simply trying to reduce etiology to keep gum disease at bay so people don't lose their teeth. Yes, that's a laudable goal. But what we're really trying to do is to keep oral pathogens to a minimum over a patient's lifetime, because clearly that's part of a strategy for overall wellness. We can do more than just clean people's teeth. Now, for certain patients, keeping the etiology to a minimum over time is really important. And this is where it gets kind of interesting. Those risk factors, those patients that are at increased risk for periodontal disease that we all learned about in school, tobacco users, patients over their ideal weight, patients with diabetes, patients with high blood pressure, postmenopausal female, and patients with sleep apnea. We know these people are more likely to develop chronic inflammatory periodontal disease. That alone suggests that we probably should pay attention to these patients. These are priority patients in whom we can't take the risk of either allowing disease to persist or allowing them to use methods to maintain it that aren't maximizing the chance that they're going to be successful. But where it gets even more interesting is when you realize that these are the exact same risk factors for cardiovascular disease. These are the same lifestyle risk factors that medicine's concerned about in terms of reducing risk for cardiovascular disease. So think about that. These people are already at increased risk for gum disease. We know without question that if gum disease is allowed to persist, it further contributes to cardiovascular risk. These people are already at increased risk for cardiovascular disease. They're at increased risk for gum disease. They're at increased risk for heart disease. If that periodontal disease isn't appropriately managed, it further increases their risk for cardiovascular disease, which is why I suggest to you, we have to change what we're doing. We have to be more successful in the war against plaque, realizing that there's a lot more at stake, especially for these priority patients. So how do we do that? Well, we, the dental therapist, has to maximally remove the etiology from the affected subgingival surfaces. And while that's a topic for another day, we haven't been completely effective in doing that. We have to maximally remove the etiology from the affected subgingival surfaces. And we're the only people that can do that. But then the patient has to maximally remove the etiology from the affected supragingival CEJ surfaces to avoid recolonization. Not using what they really like, not using what seems to be popular, not using what's going to solve them time or has bells and whistles. We have to get things relatively disease-free. And then especially for priority patients, we have to equip them with the tools that allows them to keep it that way. And to do that, they have to maximally remove the etiology from affected supragingival and CEJ surfaces. Otherwise, the disease persists. Another one of these uncomfortable truths is we have to stop doing what we deeply believe in. And as I mentioned earlier, what you deeply believe in is probably wrong. You know, there's a whole science behind why people don't believe science. Most people really don't want the truth. They just want constant reassurance that what they believe is the truth. The line for people seeking comforting lies goes around the block while no one's in line waiting to find out the unpleasant truths. The fact of the matter is, in society, and part of where we're at as a people is with complete division based on the fact that people follow what they deeply believe in. And while that might fly in society, it certainly does not for us that are healers, that are trying to improve patients' overall level of wellness. The fact of the matter is, science really doesn't care what you deeply believe. And that's one of the cool things about science. You know, science is true whether you believe it or not. We have to start considering solutions for this dilemma of significant persistence of disease, which can absolutely affect patients' overall health, by applying what science tells us. We need to take the evidence-based approach. And just a couple quick words of what the evidence-based approach really is. It's not just me waving an article that justifies what I'm suggesting, but rather it's a review of all of the available evidence, what we can say for sure based on good, solid evidence. But then to practice within evidence-based, you have to then plug that best evidence into what the specific situation that you're facing with your patient. In essence, you have to use clinical judgment to figure out what to do based on the evidence, based on your patient. Clinical judgment, by definition, is part of the evidence-based approach. We want our clinical judgment to be treatment that meets the standard of care. What is the standard of care? Well, the standard of care is not what the top 10% of dentists are doing. It's not what a dental school professor is doing, and it's not what a dental specialist is doing. Now, I speak with a little bit of authority. One of the other hats that I wear, I've done now probably about 8 or 10 expert witness testimony cases. I've been on the stand trying to support my position. And I will tell you, in an effort to cut to the chase, to meet the standard of care, what the jury is charged with determining and what your clinical judgment has to figure out is, what are you actually trying to accomplish? And then to meet the standard of care, what you use has to be reasonable. And that's what the jury's charged with determining. Was the care that was rendered reasonable based on the available evidence? When it comes to providing oral hygiene instructions to your patients, what we're really trying to do for them is to allow them to maximally remove etiology from the affected supragingival CEJ surfaces to avoid relapse of disease. That's the mandate. We want patients to be able to keep the disease from coming back. What's critical is to realize that etiology and the surfaces are what play the significant role. Yes, we have to remove plaque, and we've been focused on that for 100 years, and there's no question about it. But remember, it's bacteria in the form of a biofilm that causes that local response with potential local and systemic ramifications. Not all biofilm forms plaque. When enough biofilm accumulates and we can visibly detect it, we call it plaque, but biofilm's microscopic. We have to certainly remove any clinically detectable etiology, But we also have to take a microscopic approach, not only to our debridement, to patients' oral hygiene efforts. The microscopic aspect applies to the tooth surface itself. That's what the CEJ typically looks like. That's what the CEJ typically looks like. We have to remove from that microenvironment, yes, any plaque, now you see it, now you don't. But we also have to remove any potential microscopic biofilm, which makes you stop and wonder about what methods you're recommending now, whether they have the potential to get into those nooks and crannies based on the typical microscopic topography. How do we know if biofilm's present, the microscopic biofilm? We don't. We have no way of knowing that clinically. We have to assume at sites at which disease is present, we have to assume that biofilm is present because we have no way of knowing otherwise. The only way we can be sure that we or the patient has maximally interrupted any potential microscopic biofilm is if we expose or the patient uses a device that allows them to expose every single square millimeter of the surface to a method capable of removing any microscopic etiology. It has to do with the topography of the surface at the microscopic level. We and patients have to take a microscopic topographical approach to debridement. This is what that tooth surface looks like under high magnification. This is what tooth surface looks like on the right side, unexposed enamel, on the left side, exposed to typical day-to-day functioning. This is a person that drinks soft drinks. We have to start thinking of using something that's going to get into all of these areas to remove any potential microscopic etiology that's going to expose every square millimeter of that surface, not just laterally, but into all of the nooks and crannies to maximize the chance that health is restored, especially in those patients that are priority patients. You have to re-examine what it is you're trying to accomplish with oral hygiene. It's no longer appropriate to say, well, you know, we use this because, boy, my patients really look good and we're getting great results. You can no longer recommend a device or a technique because you deeply believe in it or because your patients love it. And I hear that all the time. In this age of evidence-based medicine, I don't think that cuts it anymore. What we're really trying to accomplish is we need to expose every square millimeter of the surface to a method capable of removing any microscopic etiology from a surface of the moon-like topography adjacent to where inflammation is noted so that the inflammation resolves and does not return. The reason you recommend a device in this age of serious dental medicine is because it's scientifically proven to do this. As healers, especially for priority patients, it's really critical for us to do that. And indeed, we want something that's easy for patients to use properly and to use consistently. We have to start thinking of patient oral hygiene at the microscopic topographical level. Only then can we maximize the chance that what we're doing is reasonable, that it's giving patients the best chance to improve not only their oral health, but their overall health. So based on that, what do we recommend? Well, I think it's probably best to break this down into buccal lingual palatal surfaces and interproximal surfaces, but not just interproximal surfaces from both the buccal and from the lingual palatal. In terms of buccal lingual surfaces, well, there's manual toothbrushing and there's power toothbrushing. That historically has been our options. But we have to be a little bit more specific than that because there's not only power toothbrushing, we tend to throw all electric toothbrushes into that category, but there's also what I like to call scientific power toothbrushes. And interproximally, yes, there's string floss that's waxed, unwaxed, dipped in stuff, coated with stuff, made to smell like stuff, made to taste like stuff. And we'll comment in just a few seconds on exactly how effective that is. There are interproximal aids, but we can't loop everything into interproximal aids. There are different types of aids. There's interproximal brushes. And in fact, to get a little bit more specific, there's correctly sized interproximal brushes. We can no longer say, well, interproximal brushes are better than floss. we have to start talking about correct size in proximal brushes. In the same fashion, yes, there are oral irrigators, most of which are like what I like to call flushers. They flush out material. But there also is a new generation of an oral irrigator that provides maximum coverage. And then lastly, there's mouthwash, which we and so many patients have relied on for so long. We have to look at each of these from the standpoint of what you're trying to do, and will it give the patient the best chance to expose every millimeter of the surface to remove any potential microscopic etiology in addition to the clinically visible etiology. So manual toothbrushing, if truth be told, it hasn't changed. It isn't modernized. All we've had since seemingly the beginning of time is a reiteration of the Miswak stick. That's all this is. Yes, now it's made out of much more expensive materials and made to look a little bit more pleasing to people. But the basic concept with manual toothbrushing has never changed since the beginning of time. Put something against the tooth surface to sweep away anything that's in its way. And because of that, the age of power toothbrushing was born. And in general, the thought was that this is an advantage because it automates the bristle movement. It makes it more likely that the bristles are going to scrape away. But as I mentioned earlier, it's critical to realize not all power brushes are the same. We want to expose every square millimeter of the surface to a method capable of removing any microscopic etiology. At the microscopic level, this is what the buccolingual surfaces look like. To simply have a patient use a manual toothbrush, to simply hand a patient any type of a power toothbrush, doesn't maximize the chance that you're going to expose every square millimeter to a force capable of removing any microscopic etiology. Philips pioneered technology that allows them to scientifically control the movement of the bristle, both amplitude and frequency. And at this specific amplitude and frequency, a significant amount of energy bubbles form in the resultant fluid. And when those bubbles break, they release enough energy to break up biofilm even beyond where the bristles are, to get into those nooks and crannies at buccolingual surfaces. We have the ability to give patients a better chance at the microscopic topographical level. In this new technology, what's of great benefit is the fact that it's more surface contact, and that's what it's all about. Oral hygiene is about maximum contact of the surface in 3 dimensions, realizing that the topography is not completely smooth. Bristles are conformed to adjust to the contour of the teeth, which give more surface contact. The sides are flexible, which gives more surface contact. The bottom line being, we have the ability, the science backs it up, compared to manual toothbrushing, superior in reducing periodontitis as measured by BOP. That's what we're trying to do. Get people relatively inflammation-free and give them the tools to keep it that way. Superior in reducing symptoms of periodontal inflammation, we see improvements compared to manual brushing in probing depth and attachment loss. We actually get reductions in the removal of plaque when we use a brush that's designed to maximize surface contact with a force even beyond the bristles that breaks up any potential microscopic etiology. So I ask you, if this is available and supported by science, why on earth do we keep handing out free toothbrushes? It really makes no sense. We dentists buy manual toothbrushes to hand out to patients. You don't leave the proctologist with free toilet paper. It really makes no sense. And of course, I know some of you are going to object and say, well, it's a practice builder. My patients look forward to it. In fact, they look forward to being able to choose the color of manual toothbrush. And yes, some manufacturers will even imprint your office number on the handle, which of course is significantly important because numerous patients in the face of a dental emergency have run to their bathroom to look at their toothbrush to figure out whom to call. We haven't given out free toothbrushes in 20 years. We don't make up the goodie bags. And the main reason is it's not the best thing for the job, especially for these priority patients. It's no longer just a matter of, well, sticking some in there and brushing. It's giving patients the best chance to do what needs to be done. And what needs to be done is to remove the maximum amount of microscopic etiology on a regular basis, which then brings us to string floss. And yes, as I mentioned earlier, I know I'm in enemy territory. You talk about dissing string floss, from my cold, dead hands where you take floss is the voice of so many dental hygienists. It's important to realize where floss came from. It isn't out of the laboratories. It's from this guy, Levi Parmley, who in 1819 in his basement picked up a piece of thread, probably off the ground, put it between his teeth, took a whiff of it, and realized that it got some stuff out. And he thought, hey, this might not be a bad thing for people to do. And he published in his Practical Guide to the Management of Teeth in 1819 that people should place a thread between their teeth as part of good hygiene practice. That was the impetus of string flossing. That's where it all started. You can make it as palatally as you want. Make it flavored with bacon. The fact of the matter, once again, few people do it. The ones that do it don't do it right. You really think your patients go home at night, take 18 inches of floss, roll it between their middle fingers, go up and down and form the letter C until it squeaks, advance it to a clean spot, go to the adjacent surface and move that up and down until it squeaks? Few people do it. The ones that do it don't do it right. But even most importantly, it's not the best thing for the job in most instances. You could go over to this patient's house every night and floss their teeth, and you would have no effect on the biofilm because of the typical contour in interproximal, especially posterior areas. In fact, you could make an argument that oral hygiene instruction led to disease in this case. There's no mystery as to why the soft tissue's here, because the bone's deteriorated. The bone deteriorated because of all this biofilm that, despite the patient religiously flossing and even using the thicker waxed floss to cover more surfaces, over the last 20 years, the only areas that were impacted by the force rendered by floss is here and here at the line angle. It typically isn't the best thing for the job. The literature backs that up. Look at the literature reviews in terms of string floss. It is concluded that a routine instruction to use floss is not supported by scientific evidence. The British Dental Association, in an editorial, suggests that flossing is a waste of time. Professor Walmsley, who's a personal friend of mine, a brilliant researcher, suggested that it's important to tell people to do the basics, of course, but string flossing is not part of the basics. Even when it comes to implants, there's now growing evidence that flossing, string flossing, is probably the worst thing around titanium. We know it's a problem maintaining titanium. There's growing belief that all floss threads, this is a clinically well-sealed implant crown on an abutment, all floss threads in those areas, and in fact has a high tendency of leading to a foreign body response. This cavalier attitude that string floss is somehow the gold standard to which everything else has to be measured has to be completely rethought. It simply isn't true. Now, I know you'll say to me, yeah, but I have a lot of patients that floss and they really look good. Well, I would say to you, first of all, you have to be a little bit more specific than they really look good. I think we've fooled ourselves a lot. That's not the criteria to which we judge the effectiveness of patients' oral hygiene. The goal is to get every site in the patient's mouth completely free of inflammation over time. Now, if in fact you have patients where every site is completely free, and it's been that way over time, and they're avid flossers, don't change a thing. Do not change a thing. Give them the instructions, keep them going. I think if we wanted to tell the truth practically, string floss works best in the patients that probably don't even need it. And yes, you'll say to me, well, how about caries? Because interproximally, you got to break that contact. There is no evidence. There is no evidence that string flossing reduces caries. The only time it ever showed any minute evidence was when it was professionally done in schools. Self-directed flossing has never been demonstrated to reduce interproximal caries. That's the facts. That's the science. There are interproximal devices, but once again, we have to be a little bit more specific about that. We want to expose every millimeter of the surface, square millimeter, to a method capable of removing microscopic etiology. Boy, these are really popular because it's really easy to get them in between the teeth, but that's not the benchmark that we're looking for. We want maximum contact. And this doesn't provide maximum contact at the ultrastructural level. There are interproximal brushes, and indeed, these have the potential to be much more effective than the use of string floss. And there's evidence to back that up. There also are evidence-based reviews that confirm the fact that interdental brushes are much more effective than traditional spring floss. The problem is, for interproximal brushes to work properly, a couple of things have to happen. Number one, you have to use the correct size. You need the largest brush that just fits to get maximum contact with the maximum amount of surface. And oftentimes, that's different in different areas of the mouth. The second thing is you got to use it in the right direction. Almost everybody that uses interproximal brushes attempts to use it from the buccal. Hardly anybody does it from the palatal. If you're only doing it from the buccal, there are areas here and there are areas here. There's no mystery why there's inflammation here. It's been untouched by oral hygiene. Oh, the patient's an avid proxibrush user, but just through the buccal surfaces. We need something that allows us to breed interproximal surfaces from both the buccal and from the palatal. After 28 years in dentistry, I've had one patient heed the message. They make a variety of different sizes, and if you're a believer in interproximal brushes, and especially if it's a patient in whom it's really critical to keep them disease-free, chances are they're going to need multiple sizes to meet the criteria of using the largest brush that just fits. I had one patient come back and he brought me this diagram. He said, "Hey, doc, I think I got it figured out." I mean, we voted this patient the patient of the year in our practice. Not many people are capable of doing this. This is a nice option, but it certainly doesn't make it as easy as possible for patients to do that. And in terms of mouthwash, and I don't want to belabor this point, but I'll simply say this too has to be revisited. We've kind of always subscribed to the uncomfortable truth that if all else fails, we'll get them to rinse with mouthwash because that'll knock out anything that's missed. The whole relationship between cardiovascular disease and periodontal disease is really encouraging us to rethink this. There is now a growing evidence to suggest that the oral microbiome is really complex, that simply introducing a chemotherapeutic mouth rinse to knock out the bad bacteria and anything else along the way might not be a good idea. There are some normal inhabitants in the mouth, some flora that the mouth needs for cardiovascular health. There's something called nitric oxide that the body uses to relax blood vessels. There's some of the oral microbiome, especially on the tongue, that's critical for the body to produce this nitric oxide. What research is finding out is that people that cavalierly have used mouthwash over the last 10, 20 years have higher blood pressure than patients that don't. And I think we have to rethink using and reaching for the mouthwash as the panacea in case all else fails. In certain patients, this might not be the best thing to do. There are oral irrigators and water flossers, which once again, I think we have to stop and be a little bit more specific. What's really critical with an oral irrigator is the force and direction. You need to position it properly and have a flow that impacts every square millimeter of the surface directly with sufficient force to remove biofilm. Now, many of the oral irrigators don't do that. Yes, they do against buccal surfaces. When directed against buccal and lingual surfaces, there's a direct 90-degree impact into the surface. The water flows at a rate that creates enough force to break up even microscopic etiology. But interproximally, where we really need it, what this does, yeah, you'll see the pieces of hamburger come out, but it's not impacting, because of the typical contour interproximally, it's not impacting those surfaces with a sufficient force to remove biofilm. Patients think they're doing a wonderful job. And in fact, they see visible stuff coming up. But remember, we have to remove not just the visible etiology, but also the microscopic etiology. Well, the fact of the matter is there's a new generation of a maximum coverage oral irrigator. Something that's easy to use properly, both buccal and lingual palatal, and provides maximum surface coverage. This Philips Sonicare Power Flosser has the potential to be used properly and to provide maximum surface coverage. Yes, it's wonderful that it's whisper quiet. It's wonderful that this new technology has pulse wave technology, which prompts the patient when to move on to the next area. And I get all that stuff. But I'm telling you, and those of you that know me, I think will realize, I'm a straight shooter. I have always been swayed by science. The fact of the matter is this quad stream technology, which is absolutely revolutionary, I think has the potential to be a game changer. I really, really do. What this quad stream technology is, instead of the stuff coming out in one direction, it comes out in 4 different directed streams to allow maximum surface contact, especially in priority patients, especially patients who have had a history of gingivitis or have sites that haven't resolved. This finally gives us something that maximizes the chance that we're going to expose every square millimeter to a force directed in a way that interrupts even the microscopic etiology. When you talk about interproximal surfaces, finally, we have the potential to do that. The science is there, 150% more effective than string floss in the traditional parameters of gingival health. 99.9% more plaque removal from treated areas, maximum surface coverage. And compared to a single jet irrigator, what I would typically call a flusher, 9 times more surface area covered. Your patients that have every site in their mouth that are relatively healthy, do whatever you're doing. Continue doing it. For sites that haven't responded to treatment, for sites that are diseased, give your patient the best chance to achieve the desired outcome. Science tells us that you must be willing to truly consider the evidence that contradicts your beliefs and admit the possibility that you may be wrong. It's understandable that we're reluctant to do that. It's human nature to do that. But I think it's important to realize that intelligence isn't knowing everything. It's the ability to challenge everything you know. I have a healthy level of skepticism. I'm not swayed by marketing. I'm not swayed by emotion. I'm recommending the Power Toothbrush and the Power Flosser, not because I love the products. I'm recommending an outcome. And the outcome is to get patients relatively free of disease over their lifespan, because it's really important for patients to do that. These products are essential to getting the maximum removal of etiology necessary to achieve the outcome. Science tells me that. My clinical judgment tells me that. That's why I tell my patients to use this. We're in the age of serious dental medicine. We have to realize that for certain patients, it's a whole new ballgame. We have to give them the maximum chance to improve their oral and overall health. We have to get off this brush and floss or else. I'm encouraging you today. I'm imploring you. I'll beg you if I have to, take down the decoupage plaques that you still have in your offices that say you don't have to floss all of your teeth, just the ones you want to keep. Or the other ones that say floss them if you got them. That's old school. in this age of evidence-based serious dental medicine, we have to rethink the oral hygiene approach. I think a better way, rather than telling everyone to brush and floss, is to first find out if the patient's a priority patient. And if so, if they're in that category, they're a tobacco user, they're over their ideal weight, they have diabetes, it's a postmenopausal female, they have high blood pressure, it's a patient that has sleep apnea or screens at risk for sleep apnea, maximize the chance that they're going to achieve the desired outcome, which is to remove the etiology in all of its forms. Secondly, what are the surfaces in that patient that needs debridement? Make a surface-specific recommendation. What's the best thing for those surfaces? You need to choose something based on microscopic and the topographical nature, and then fulfill the role of, are they using it effectively? Are they using the right thing, and are they using it properly? But I think question number one has to be, what does science say will give the patient the best chance to consistently and effectively remove clinical etiology and any potential microscopic etiology from every square millimeter of the involved tooth surface? When new devices become available, when you're revisiting what you use now, try and resist looking at what you deeply believe in. Re-examine everything. Put it to the test. What does science say about what you're recommending? Does it give the patient the best chance to consistently and effectively remove not just what you can see, but any potential microscopic etiology from a surface of the tooth that typically isn't smooth, that it certainly isn't glassy smooth? To do that, especially in priority patients, especially in patients that have implants, maximizes the chance that they're going to achieve a preferred level of oral health. And a preferred level of oral health is an important component of overall health. It's because of the evidence-based approach. It's because of wanting to meet the standard of care in this age of serious dental medicine that I give my patients the possibility of maximizing the chance of achieving the desired outcome. And I think it's really critical to do that. Now, the fact of the matter is, lastly, we will make it as easy as possible to follow up on all of this information. I put up a website for continuing education information, beyondthemouth.com. I joined the podcast generation, and about a year or two ago, put up some podcasts. We, of course, measure the metrics. I'm happy to report to everybody tonight, we have a fabulous crowd tonight, that of the podcasts that are up there, I've had 3 people listen to them over the last 2 years. And I know my mother's listened once and I've listened once. So whoever the other person was, I thank you. I'm not directing you to beyondthemouth.com for the podcast, although you might find some of them useful. But more importantly, you can get all the material from today's course. If you go to beyondthemouth.com and you click on seminar events, you'll be taken to a page where you're prompted to sign up. You enter a username and password, and then you can use that username and password immediately to go to the registered users download page. And at the registered users download page, you're looking for the folder that is 2022 Uncomfortable Truths About Oral Hygiene. And in that folder will be the presentation as it's given here today. And I just uploaded that right before we went live with the presentation. The literature that we talked about today. There's an article that I wrote recently for Dental Economics that dentistry needs to change its narrative. All of that information is available to try and encourage you to similarly take a different approach. We're in the age of serious dental medicine. It's time that we do more for patients' overall health in addition to their oral health. And if there's any follow-up or issues with that, there's a great big email button, and please feel free to reach out anytime and do that as well. I thank you amazingly for your attention, and we have the ability to do some Q&A. And if you give me a second to pull those up, what are your thoughts on best professional care, thoughts on GBT? And I assume by GBT, you mean guided biofilm therapy. And that guided biofilm therapy, which is, air polishing with a variety of materials, absolutely positively has potential. And certainly supragingivally has the potential to remove stain and even biofilm, and there's evidence to back that up. But once again, remember, we have to direct whatever the force is, whether it's water, whether it's glycine powder, whether it's a toothbrush bristle, we have to direct it against the surface that you're trying to adequately debride. Well, air polishing does a magnificent job facial-lingually, but it's really difficult to get that to impact those interproximal recesses at the force necessary to break up microscopic biofilm. It certainly isn't my go-to in terms of adequate debridement on my part. And even subgingivally, the guided biofilm therapy is supplied. There's a couple different devices to deliver subgingival air polishing. And those devices are promoted to be able to deliver it subgingivally, which in the laboratory makes perfect sense. But realize in the pocket, that's a really harsh environment. There's a whole lot going on there as to whether that material comes out and impacts subgingivally. That's the bottom line, that I'm not so sure that that's the panacea for it. Another question that we have is, do warm saltwater rinses help with inflammation at all? Which gives me another opportunity to kind of clarify. In terms of best practices, we have to realize that chronic inflammatory periodontal disease really is a systemic disease with site-specific presentation. Yes, we manage patients systemically and try and modify the modifiable risk factors, but it's a site-specific disease. And what we need to do is expose especially the surfaces adjacent to where sites are diseased to forces, devices that are capable of interrupting not only the visible etiology, but microscopic etiology. Rinsing, whether it's with warm salt water, whether it's with water, certainly has the potential to flush away debris. But simply rinsing doesn't deliver the material with the impact against the surfaces that we need it to deliver, that needs to be delivered against. We certainly don't rely on mouth rinsing as being the solution to getting the affected surfaces. Let's face it, the most likely area where disease exists. I've made my living as a periodontist treating interproximal disease. That's in the majority of patients where it is, because it's really difficult for patients to adequately maintain it. Whatever you're a deep believer in, use warm salt water, use a chemotherapeutic mouth rinse. But then in addition to that, use science to determine what's going to give the patient the best chance to affect the surfaces where the problem is. This isn't a question, but I will read it publicly. Thank you for a very enlightening and innovative lecture. Yeah, you're quite welcome. I thoroughly enjoy taking the science and packaging it in a way that makes sense, and I hope we did that tonight. Floss can get under the gingival sulcus when wrapped and moved under the gingiva. Water picks cannot. And I'll decipher that. And indeed, if the tooth surface is completely round interproximally, and if you have somebody that's able to manipulate a piece of floss under the gingival sulcus and then move it so that it creates force to break up biofilm, there's no question that that can work. Most tooth surfaces aren't shaped like that under the gingival sulcus. Most tooth surfaces aren't completely round and convex. There are concave areas. And then when you look at what the tooth surface looks like under high magnification, there's no way. There's no way that string floss is getting into those nooks and crannies. And indeed, a single irrigator delivery of fluid doesn't readily get to some of these areas. But if you have the ability to direct the water at a force in multiple directions, and if you couple that with the ability to not only sweep things away with the bristles, but then to capture the energy of the way those bristles move and impart energy, all of a sudden you're greatly increasing the likelihood that you're going to give patients the potential to maximally interrupt the etiology. My whole message is for certain patients, it's really important to do that. Another question with decay that we see initiating on the direct interproximal contact: how can anything other than floss effectively remove bile from the contact areas? Well, as I said earlier, and while it's understandable to think that way, the research says otherwise. The research does not support the use of string floss. Now, I get it. The concept is we're thinking, well, what that's doing is when a patient eats, there's going to be food that's jammed right at the coronal portion of the contact, and food that remains at the right underneath the contact that nothing else is going to get to unless you break through that contact. Once again, you have to think at the microscopic level. Teeth aren't static. If you looked at a high magnification of teeth, even at rest, with every heartbeat and every change in blood flow, the teeth move up to about 1/4 of a millimeter because of the periodontal ligament. We don't have areas that debris can only be reached by floss, which is why the evidence suggests that there is no benefit in terms of reducing caries. There's no more caries in people that floss than there are in people that don't use floss. Now cleaning interproximally is really critical. Don't get me wrong. However, the science says otherwise. And I think it's because that whole concept of breaking through the contact, that really doesn't hold up when you realize that debridement is the microscopic topographical level. Because of the normal functioning of the teeth, it is possible to adequately achieve debridement to where there isn't increased risk of caries, there isn't an increased risk of periodontal disease. Now, to do that, we have to use science. We have to figure out, what does the surface look like microscopically, topographically, and what will give the patient the best chance to debride that. Now, and I hope that makes sense. And I know that's a tough one for some people to get to. If that needs further clarification, then please reach out to me, and I'd love to have that discussion. Another question: are there brands besides Sonicare that use similar technology? There aren't. And as I mentioned earlier, and I'll reinforce that, as I said, I'm not a cheerleader for anybody. I've hopefully established my reputation in providing CE of being science-based. I'm swayed only by the science. This is indeed a potential game changer because of the fact that we're able to get the force directed in multiple directions. This is the only one that has that technology, which I think speaks highly for the fact that, and what we need in dentistry to change the narrative, is we need all the stakeholders to realize we all got to do a better job. We really do. The excuses, we're running out of excuses for letting people walk around with so much disease. Companies such as Philips have determined that there is a better way to do things. They put the time, effort, and research into doing it to come up with technology. Change is a part of a healthcare profession. All I'm asking you to do is, as changes come through, put it to the test. Put it to the test of what the science says, what your clinical judgment says, to give patients the best chance. And we're coming up close to the time. We'll sneak a few more questions in. Do you get payback from Philips Sonicare for promoting their products? Boy, I wish I did. Believe me, I wish that I did. I don't. If you're not familiar with me, I will reassure you, as I've said numerous times, I support what I have determined in clinical judgment makes sense from a scientific standpoint. And I've done that throughout my entire career. Is there any benefit to medicaments in the water device? Now, if you're talking about patient delivery, if you're talking about therapist devices, like, for instance, ultrasonic devices that use medicaments, studies have been relatively consistent that there really isn't any great benefit to using medicament. Now, and I know it's tempting to think, man, it's got to help. At least it will knock out some more bacteria. But a couple of things make me hesitant. Number one, research has never supported that. And I think, for instance, like with ultrasonic instrumentation, the reason research hasn't supported that is it's not, and the same thing with a scientifically designed multi-direction, water delivery, water flosser device. Science designed it to get impact of the force of the fluid. It's the force and the direction that it goes in, as opposed to what the fluid is. The second hesitation that I have, as I mentioned earlier, that this whole dental approach of dumping as many chemicals into patients' mouths to see, kind of throw it all against the wall and see what sticks, might not be as harmless as we originally thought. Specifically with chemotherapeutics, there are some bacteria in the mouth that need to remain in the mouth and not be widely killed on a daily basis for overall health. And lastly, let me see, I think there was one more that popped up. All right, one more great presentation. What would be the best oral hygiene instruction, home care for high caries risk patients or chronic periodontitis patients? And we'll close with this. I think we have to look at, in terms of what's best for both high caries risk and for chronic periodontitis patients, I think we have to first come to terms with the fact that it's microscopic etiology that causes both. It's microscopic etiology that causes both. So if you want to maximize the chance, you have to give patients the ability to interrupt as much of the microscopic etiology as possible. Now, with caries, there's the potential to do some things to make the enamel less susceptible to the carious attack, to strengthen the enamel. But even in the face of trying to boost resistance, what we need to do for patients that are at risk for dental disease is give them the ability to maximally control the microscopic etiology. We haven't done that. We haven't done that because we've done what we deeply believed in. We've thought, well, at least if they're brushing, I really like this. I'll have patients use this. They really look good. My patients look so much better. We have to start looking at debridement, both by patient and therapist, at the microscopic topographical level. The end point is the long-term stability, long-term suppression of disease at sites in a patient. Only then can we say that we've maximized the chance for this patient to enjoy the benefits of oral health and the benefits of overall health. We have a real potential to do that for patients. We're really at the brink of claiming our rightful place on the healthcare stage after so many years of being considered as nothing more than the oral hygiene police. To do that, we have to take a scientific approach. And I hope tonight has helped everybody to at least consider doing that. I greatly appreciate the attention. We will sign off for tonight. I will look forward to any further contact that we have, and I'll see you sometime in the future. Have a great rest of the day.